Hello. Thank you for showing up and thank you for reaching out. My name is Arian Smith, and I put together a medical family therapy presentation for y'all since you were really interested in finding out more about medical family therapy and seeing if it's a good fit for you. Okay, let's get started here. So the agenda throughout this presentation, we're going to be looking at describing what MedFT is, what medical family therapy is, discussing the full world view overview. We're going to be identifying screening protocols, describing the workflow, identify behavioral health interventions, and compare individual versus family. So, just starting off, what is MedFT? What is medical family therapy? The definition is a biopsychosocial systemic approach integrating family therapy into the medical setting. And our focus is treating or treats health problems as relational, contextual, and embedded in families and communities. Right? And the roles is embedded clinician, care, coordinator, and consultant. Right? I think the topic is more focused on making sure we're delivering the needs to the family overall rather than just the individual. And we'll get into that a little bit later as well. So the evolution of medical family therapy, right? The beginning, the origin of family therapy and behavioral medicine traditions. It moved from specialty mental health to integrated primary care and chronic disease settings. Some of the drivers of growth were evidence for behavioral interventions and health outcomes, collaborative care models, and value-based payment, recognition of social determinants to health as well. So today, a big part of the evolution for medical family therapy is being a part of the interprofessional teams in hospitals, clinics, and community health. So the full world view overview, right? The full world view, we're looking at the clinical world. Will this work for the patients? The operational world, can we make it work in a daily clinic slash flow? Financial world, can we sustain it financially? If we use this model, if we use MedFT, can we sustain it? And the training world, do the staff have the skills? How can we make sure that everyone participating in the MedFT, not just the medical family therapist, but every staff involved in the treatment, how can we make sure that they have the skills ready to implement this type of care? So we can start off with the clinical world. The clinical world, we're delivering evidence based care that improves health and family functioning. Universal screening and measurement based care, right? Everything's standardized, and some things are going to be more available than others, but there's generally a baseline between what screeners and protocols you could use. Intervention, so brief CBT, nothing that's too long term, but CBT just focusing on function improvement and symptom reduction. MI, motivational interviewing, family therapy, and psychoeducation. I think psychoeducation is one of the biggest interventions as well when it comes to providing a family style oriented learning when it comes to making sure that a family is understanding what the situation is with the patient or the client and how can everyone involved be there for the patient and work together. And some of the metrics here, we're using symptom reduction, adherence rates, family functioning scores, and patient satisfaction. Now we're moving on to the operational world, right? Which is embedded in workflows and routine clinic flow. The staffing, zero point 0.5 to 1.0 FTE med FT per clinic panel size. Screening at intake, annual visits, warm handoffs, same day consults. Right? So a lot of the EHR tools, we're looking at screening templates, alerts, dashboards, things that gets all the multidisciplinary team involved. And some of the metrics we're looking from time from screen, right? The screening process to the contact, how much percentage of warm handoffs, and then also keeping track of the no-show rates, right? We need to make sure that everyone's being involved and everything is working from the patient to the person to the family back to the staff all around. Next, we're looking at the financial world, right? Because a part of using the MedFT is making sure that it still works for you financially. So a lot of the times, the biggest parts are the billing, the funding, cost offsets, and metrics. So looking at the billing, we're looking at CPT psychotherapy codes, right? The cognitive processing therapy, psychotherapy codes, collaborative care codes, and incident to billing, right? A lot of insurance needs a some keywords. Insurance needs to know the things that we're working on in therapy, especially if it's a medical family therapy. Why is it important? Why are we billing for it? Funding, right? You can fund this with startup grants, value based payment incentives, things that other companies or other parts of organizations could reach out to and start helping pay or fund certain programs like the MedFT program, or if that's something that you wanted to add right to your facility. I think this is something that you could look into. Some of the cost offsets, right? So reduced ER visits and better chronic disease management. A lot of the time, having a patient that is discharged from the hospital or from the facility or from the clinic, wherever you are, and they come back, a lot of times that cost eats up more than if we implemented and ate the cost of introducing the MedFT program or MedFT therapist, whatever you want to call it. And it over time will offset the cost of introducing it rather than having the patient come back over and over and over, or the family send them back to the ER over and over because they don't know how to deal with it. So, additionally, we're looking at the metrics as well, the ROIs, break even point, payer mix analysis. So, a couple key points on the side here: financial sustainability over 3 to 5 years, fewer missed appointments, and improved patient retention. And also paying attention that if you could do telehealth billing is optional for remote sessions. A lot of the times it's continued care outside of the session where you don't even need them to come in, and you could still bill for that and have remote sessions because they may be not able to come to the hospital, or they just need continued help being to live, and the family being able to check in and knowing that they're doing the right thing. So we also have the training world, right? The core skills, MedFT approaches, integrated care, cultural humility, MI, motivational interviewing, and CBT informed interventions. We have the orientation, where all clinic staff are trained on screening, warm handoffs, and confidentiality for family work. Ongoing, so we have weekly supervision, fidelity checks, and role plays. I think the biggest thing too is sometimes when we don't have to get to the first time having to experience something. I think the role plays allow the team, the multidisciplinary team, to interact within each other, for have a role play scenario of a patient that they're taking care of, and be able to work together to find solutions and create a better experience for the patient and better outcomes, better success. And weekly supervision, being able, if you have any questions, please ask each other, ask the supervisors. There's always going to be somebody that you could ask to go to, and they'll be able to have an answer, if not be able to get an answer for you, because we all want everybody to work together. And some of the metrics we're looking at are percent staff trained, the competency scores, and retention. Yes, there's going to have to be a test at the end of this training because we just want to ensure that you're able to get the right percentage of competency to make sure that you're able to practice and able to continue using MedFT, and making sure it's implemented throughout the whole hospital facility, etc. So some of the screening protocols MedFT uses, right? We're looking at universal, which is all the patients. We could look at the PHQ-2 to the PHQ-9, which looks at your which looks at general depression. We have the audit C, right, dealing with alcohol if it's a single item drug screen, and after that, it will go right into the DAS-10 if it's positive. And then we look at some social determinants, right? The prepare or the AHC, HRSN, making sure those determine whether or not those are used to determine any social factors. And if any family or relationship concerns, we still have family functioning screenings, the FAD, or any of the SCORE 15, right? As indicated, we still have the GAD-7, right? The GAD-7. We're looking at general anxiety disorders, or the PTSD-5, or any suicide risk, the Columbia Suicide Scale rating. Anything like this, these are general screening protocols are going to be used within the medical family program or the medical family therapy, as well as throughout the hospital, and all the teams that need to be using it. So we're looking at some workflow for positive screens. So if they are positive to any of these screenings, right, or certain screenings, we have a CEHR alert, right? Then we staff notify any PCP or MedFT, specifically on the MedFT part here. So we have safety checks if it's a flagged risk, or anybody go ahead and says yes, suicide ideation. I have a plan intent. We do some safety checks, and we make sure we have a warm handoff to the MedFT the same day if possible, right? Because the MedFT is going to be able to provide care and be able to have them work with another part of a department, work with the family, and then the next step would be a comprehensive MedFT evaluation within 1 to 2 weeks. So the intervention path, we're looking at low complexity, some brief interventions. Moderate slash complex, we're looking at some short term family system therapy. But if it's high acuity, we have some specialty referrals that we'll be able to get into later as well. So, and then finally, we have ongoing monitoring and outcome measurement. We want to make sure that not just in the hospital that they're doing okay and doing fine, functioning. It's all about outside of the hospital as well, or outside of the clinic, making sure the family is taking care of them, and that that they're also doing what they need to do, which they have been practicing in the hospital. So we're looking at some behavioral health interventions here as well. Right. So there's some brief CBT informed therapy, right? Behavioral activation, PST, motivational interviewing, adherence, substance use, brief family therapy, structural, psychoeducational. I think psychoeducation, like I said earlier, is one of the biggest things for these families to understand. Instead of pushing it off and not understanding what's going on, they're able to understand and be a part of the treatment. And then we have trauma informed care, right? TFCBT for the youth. TFCBT is huge when it comes to dealing with trauma or any sort of trauma informed care when it comes to children, because it's not always just adults, right? When MedFTs can work with trauma youth or traumatized youth. Then we have parent training for child behavior. Parent training allows the parent to be trained. There's no guideline or blueprint for how to be a parent. And especially if we have the resources and get trained on the resources, we can provide those and allow parents to feel more comfortable and confident training with consistency and the betterment of the child, patient, etc. So we have care management as well. So collaborative care model. We want to make sure that everyone is taking care of the patient, and that includes the family, the staff, the doctors, the patient themselves. Everything is collaborative because we work together. Oops, excuse me, going the wrong way there. So adapting to social location, right? So it's important to know we have language literacy. Did I skip one? Let me double check. Nope. Okay. Perfect. So, adapting to social location, we have language literacy, use preferred language, plain terms, cultural values, understand to integrate their beliefs, involve in community supports. We also have to understand that there are social economic status constraints, flexible scheduling, telehealth, CHWs. We have to understand that not everybody's on the same uh, timeline, the same SES, the same cultural. Everybody's different, so we have to accommodate to that. LGBTQ plus care, we have to use inclusive language. Make sure it's a safe space for everybody to share and be a part of this ongoing treatment. And if it's rural, do we have telehealth for them? Are there local partnerships? And also digital literacy, simple tech, phone visits, reminders, things where people, if they feel like they're not adequately prepared to handle the digital part of it, there are simple things that we could teach them, have them learn, and then they can continue using so we can monitor ongoing healthcare. So, the difference between individual and family therapy, the individual plan, there's the focus, which are the symptoms, coping, and adherence. Interventions, you could be CBT, motivational interviewing, and behavioral analysis. Some of the outcomes we're looking at are PHQ-9s for depression and our GAD-7s for our anxiety. Well, when we look at the family plan, the whole focus is making sure that the relational patterns and the caregiving is all a part of the communication as well. We're making sure everything comes together in the family plan because it's a collaborative experience that allows the patient to get better rather than just the patient dealing with it on them by themselves. So, our interventions were family therapy techniques and psychoeducation. Some of the outcomes, the family functioning, FAD, and the score 15, and the caregiver burden. So 90-day implementation roadmap. We have phase 0, week 0 through 2, prep leadership buy-in, hire MedFT EHR build. Phase 1, weeks 3 to 8, train staff, start screening, pilot MedFT hours. Phase 2, weeks 9 through 12, review data, adjust workflows, and add trainings. Ongoing monitor metrics, quarterly review, continuous improvement. So some of the key metrics clinically, we have symptom change, adherence rates, family functioning, operational, percentage screened, warm handoff rate, time to BH contact, financial, ROI, review, revenue cost savings, training, staff trained, skill ratings, and retention. So risk and mitigations, low PCP buy-in, co-location, and show quick wins. There's billing challenges as well, early billing team involvement and team involvement, confidentiality issues, standardized consent process. So, and then also burnout risks lead right into managed caseload and supervision. We have the risks that are popping up and we have ways to mitigate it or ways to lower that risk. And it shows here, right? So, with all that said, that is the MedFT. That's the medical family therapy program or medical family therapy incentive where you're able to gather this information and see if it's a right fit for you. If there, my name is Arian Smith again, and here's my email right here, asmith17 at alliant.edu. And this is the school that I also attend here. And if there's any more information, please reach out. I hope MedFT works for you. And thank you for reaching out. I hope this presentation helped.